Hi everybody, today we will be discussing December 2021 paper 1 question number 5. Here they have asked enumerate the plain radiography, that is X-ray findings of two diseases, that is Perthes and Ewing Sarcoma in femur. For each one they gave 5 marks. So first coming to Perthes disease, leg claw Perthes disease. So it's an avascular necrosis of the femoral capital epiphysis before the closure of the growth plate. That is, it occurs in children. Before the closure of the growth plate, avascular necrosis of femoral capital epiphysis. So it's a self-limiting, resolving within 2 to 8 years, but resulting in various degrees of deformity. Coming to age group, 3 to 12 years, they have a male predominance like 5:1. In 10% cases, they are bilateral. Coming to clinical features, they present with a vague groin pain with extension into the anteromedial knee. They present with limp. They'll have like abduction, internal rotation, leading to pain within the hip. In chronic cases, there is prominent atrophy of the thigh muscles. Coming to pathology, there are 3 people. There is leg, claw and Perthes. So each one gave one cause for Perthes disease. Perthes, he told infection is the cause for this. Claw, he told rickets. Leg, he told trauma. So what are different causes of Perthes disease? We have hereditary, trauma, endocrine disorders, inflammation, nutrition related, altered circulatory hemodynamics. Here what happens? There will be disturbed venous drainage and intraosseous hypertension. These are the important factors. In the majority of cases, the bone age is reduced by 50% of the chronological age. So pathology, what happens? Why avascular necrosis occurs? Coming to femoral head, vascular supply, normal vascular supply. This is a femoral head. We have foveal vessels. Foveal vessels. Through foveal vessels, the femoral head get blood supply. The foveal vessels, they penetrate to the ligamentum teres. This is ligamentum teres. From here we get the foveal vessels. Then we have superior and inferior epiphyseal vessels originating from the medial and lateral circumflex branches of the profunda femoris. There is a profunda femoris artery. It has a circumflex branch, medial and lateral circumflex branches. From there we get epiphyseal vessels. They are medial and lateral epiphyseal groups. Medial and lateral epiphyseal groups. Then we have metaphysis, metaphyseal vessels from the bone marrow. So they have 3 vessels, remember. One is foveal vessels. They penetrate to the ligamentum teres. Then we have medial and lateral circumflex branches of the profunda femoris. From there we have superior and inferior epiphyseal vessels. Then we have, these are epiphyseal vessels. Then we have metaphyseal vessels. They come from the bone marrow. Then most important is the lateral group. Coming to vulnerable period is between the age group of 4 and 7 years. This age group, it corresponds to the age of onset of the disorder. During the age of 4 and 7 years, contribution by foveal and metaphyseal vessels are negligible. We have foveal vessels, we have metaphyseal vessels, we have epiphyseal vessels. During this period between 4 and 7 years, contribution by the foveal vessels and metaphyseal vessels is negligible, will be less. So majority is being derived from the epiphyseal vessel, especially the lateral group. So the whole burden, it falls on this epiphyseal vessels. This solitary source of blood vasculature may predispose the patient to ischemic necrosis by not allowing for a alternate collateral supply if these epiphyseal vessels become obstructed. So what happens during 4 to 7 years? Foveal and metaphyseal vessels contribution will be very negligible. The whole burden falls on the epiphyseal vessel, that is that to lateral group. So this solitary source of blood vasculature, this predisposes the patient to ischemic necrosis of not allowing for an alternate collateral supply, by not allowing, and if these epiphyseal vessels become obstructed. With progressing age, greater contributions are made by the foveal and metaphyseal sources, reducing the vulnerability during the developing ischemia. The position of these epiphyseal veins and arteries on the surface of the femoral neck in a subsynovial location renders them vulnerable to disruption from fracture, slipping of epiphysis, intracapsular synovitis, and surgical pinning. Now, between 4 and 7 years, majority of burden is on the epiphyseal vessels. Suppose in these kids, if they have fracture, slipping of epiphysis, intracapsular synovitis, or surgical pinning, as these vessels, that is the epiphyseal veins and arteries, they are on the surface of the femoral neck in a subsynovial location, they are more vulnerable to damage. Then coming to 4 phases. There are 4 phases in Perthes. We have avascular phase. First there will be no blood supply leading to avasculature. Then alternate revascularization starts, then repair, then deformity. The entire process of initial infarction to residual deformity takes a variable length of time between 2 and 8 years. Then coming to pathology and radiological findings. So avascular stage, what are the radiological features? Capsular distension, increased joint space, lateral femoral displacement, and small epiphysis. Then coming to revascularization, that is between 6 months and 4 years. There will be flattened small epiphysis, fragmentation of the epiphysis, sclerosis of the epiphysis leading to snow cap sign, increased cortical density, given head within a head appearance. Metaphyseal cyst will be there, patchy sclerosis will be there. Subchondral fractures will be there, giving the crescent sign. Wide short femoral neck will be there. Repair and remodeling. There will be gradual reconstitution of the density and configuration. Coming to this is for 1 to 2 years. Then last will be the deformity. They have coxa vara, enlarged head, that is coxa magna, flattened head, that is mushroom deformity, coxa plana, and large greater trochanter. Then coming to, before going to radiological features, I'll be telling something like what are the normal fat. This is a hip joint, part of hip joint. Normal fat folds will be present in all hip joints. Hip joint x-rays, normally they are radiolucent fat folds. We have 3 here. One is the gluteus medius. It is located lateral to the femoral neck. Another is the iliopsoas. It is superior to the lesser trochanter, and obturator internus. It is medial to the pelvic brim at the iliopectineal line. So we will see in the radiological features what happened to these fat folds. So roughly I'll be telling you, these are all this diagram, it represents early radiographic signs of leg clot Perthes disease. So here we have femoral head, metaphysis, growth plate, femoral neck, and we have diaphysis. Here we have greater trochanter, lesser trochanter, teardrop, coilus teardrop, obturator foramina. So what will be there? People with leg clot Perthes disease, they have small epiphysis. They have subchondral fracture, that is crescent sign. This is a fat fold. This is gluteus medius fat fold. Here it is bulged, that is convex distended pericapsular fat planes. We have enlarged greater trochanter. We have broad short femoral neck. Lateral epiphyseal and metaphyseal lucency is called gauge sign. We have linear metaphyseal lucency. We have medial metaphyseal cyst. In metaphysis only we have cyst and lucency. We have medial metaphyseal cyst, linear metaphyseal lucency. Lateral epiphyseal and metaphyseal lucency is called gauge sign. Then we have widened growth plate, increased medial joint space. Here we calculate between the medial teardrop and the medial aspect of the femur. So this will be widened. There will be increased medial joint space, small obturator foramina. So we'll be discussing all these features now. Coming to first radiological feature. Soft tissue swelling will be there. These are all X-ray features. Soft tissue swelling. Normally when you see soft tissue, there will be soft tissue swelling. Why there will be soft tissue swelling? This is due to intra-articular hip effusion. Comparison with contralateral side should be done. Careful clinical correlation should be done. Look at the pericapsular fat planes, especially on the lateral aspect of femoral neck, that is formed by the gluteus medius. So you see the fat plane, pericapsular fat plane, especially along the lateral aspect of the femoral neck. So here normally you can see this is one of the fat plane, radiolucent fat plane. The muscle located here is gluteus medius. Normally it is concave. It has a concave contour of the pericapsular fat plane. This is a normal fat fold. So in these people with Perthes disease, in the starting stages they have effusion. This leads to there will be convex contour of the fat folds that is deviated beyond the normal anatomic position. Normally it should be concave contour. Here we have convex contour. So look at the soft tissue swelling. Clinically they have look for any joint effusion. Look at the pericapsular fat planes, especially on the lateral aspect of the femoral neck. To see on X-ray, increased medial joint space. There is one of the sign called Waldenstrom's sign. What is this? This increase in the width of the medial joint cavity of the hip joint with an accompanying lateral displacement of the femur. This is due to effusion or cartilage hyperplasia. So here you can see this is how you measure it. This is the coalesced pelvic teardrop. Here you have medial aspect of the femur. The distance between this, we can calculate the joint space. This is a medial joint space. In Perthes disease, this medial joint space is increased. Normally here measurement of more than 11 mm or a difference in measurement of more than 2 mm compared to the opposite side is a positive sign. Then coming to small obturator foramina. Not a specific sign, often being present in any painful condition of the hip. So when you compare with the opposite side, this obturator foramina is very small. Why the obturator foramina is small? This is due to projectional distortion of the pubis and ischium. Projectional distortion of the pubis and ischium. Secondary to antalgic flexion, external rotation and slight abduction of the involved hip. Due to pain, positional change, there will be small obturator foramina. Here you can see even small femoral sclerotic, there is a small sclerotic femoral head epiphysis. There will be reduction in overall size of the femoral head, may be the only radiographic sign early in the disease. It appears to be the result of why there will be a small femoral head due to lack of growth because of impaired blood supply. The main basic component, blood supply will not be there, growth will not be there, small femoral head rather than osseous compression. No blood supply, no growth, leading to reduction in the overall size of the femoral head. Then coming to wide teardrop size. Here we can see this is a teardrop. This will be widened. What happens here? There will be atrophy of the gluteal muscles on the affected side. Okay. This allows slight obliquity to occur in the pelvis at the time of radiographic exposure is taken. So on the affected side, gluteal muscle atrophy will be there. When you are taking an X-ray, there will be slight obliquity to occur in the pelvis at the time of exposure, projecting the widened teardrop contour. This is mainly due to atrophy of the muscles while you are taking an X-ray, due to it gets projected like that due to obliquity. Then coming to fragmentation. Loosened clefts of varying sizes visible traversing the epiphysis, often the first detected osseous change. Here what happens? There will be one sign called crescent sign or rim sign. This is the femoral head. Curvilinear loosened defect paralleling the superior weight bearing articular surface. This is a crescent sign. What is this due to? Subchondral fracture. In frog-leg position, what happens? This is frog-leg position. Nitrogen gas may collect in this subchondral fracture. Nitrogen gas may get collected in this subchondral fracture so that we can see it more clearly. This is called presence of gas produced by the position. This is a frog-leg position. Then coming to sclerosis. Okay. Involved epiphysis, there will be increased density, manifestation of revascularization, newborn deposited directly over a dead tubercle. This radiographic sign of attempted healing. This causes sclerosis. There are 3 patterns of sclerosis apparent at a specific time period. Peripherally at the articular cortex, sclerosis giving an head within and head appearance. Patchy, like segmental sequestered areas, or homogeneous sclerosis giving snow cap appearance. It can be homogeneous, it can be patchy, it can be peripherally located. On MRI, sclerosis low signal intensity with a normal fragment showing intermediate signal intensity. Then coming to metaphyseal widening and shortening. Femoral neck widened transversely and decreased in overall length. The most lateral cortical margin is often convex rather than normal concave. Broad, short femoral neck likely cause oppositional bone growth by the periosteum and cessation in the longitudinal growth by the physis. Obviously, no blood supply, longitudinal growth will not be there. There will be bone growth by the periosteum, so it will be widened. So broad, short femoral neck will be there. Coming to metaphyseal cyst, this is our metaphyseal cyst. Represent displaced, uncalcified growth plate cartilage, occur along the lateral and medial aspect of the neck, found late in the disease, will eventually disappear. A loosened defect at the lateral epiphysis and adjacent metaphysis, that's called gate sign, may occur early in the disease and may be an indicator of worse prognosis. This is in radiolucency, the lateral metaphyseal margin. It represents cartilaginous intrusion from the adjacent physis. So metaphyseal cyst will be there. They are found late in the disease. One more called gaze sign. It is like loosened defect at the lateral epiphysis and adjacent metaphysis. This occurs early in the disease and indicator of worse prognosis. Coming to enlarged greater trochanter. Decreased longitudinal growth of the femoral neck with continued growth of the greater trochanter. Greater trochanter will be continuously growing. Femoral neck, due to decrease, but longitudinal growth will not be there, just widened. So it appears as if greater trochanter is growing out of proportion to the neck. Clinically, this elevates the trochanter slightly and impairs the power of attaching muscles and producing abductor insufficiency and a positive tendon blood test. There will be radiolucent physis may appear widened and irregular, especially of the metaphyseal side. Linear radiolucent submetaphyseal band may be evident. Orientation of the growth plate may become more horizontal than normal. Acetabular roof at its lateral margin is occasionally irregular. On MRI, femoral cartilage at its lateral and medial margin is often hypertrophied and bulging. Less than 5% of cases, late complication is detachment of an osteochondral fragment, that is osteochondritis dissecans. So it occurs like 8 years after the diagnosis of ischemic necrosis. In 5% of cases, loss of joint space may occur over 1 year, leading to stiff and poorly functioning hip. This chondrolysis requiring early surgical intervention. Older the patient at the time of onset of the Perthes disease, higher the incidence for osteochondritis dissecans. After completion of the disease process, reconstituted femoral head may appear. This is important. Reconstituted femoral head may take one of the configuration, like there will be overall enlargement of the head, that's coxa magna, or flattening of the head, coxa plana, flattening and increased transverse diameter, that is mostrum deformity. So coming to the diagram, short femoral neck, short wide femoral neck, femoral head showing a flattened configuration. When you come to this, it shows an mushroom deformity, enlarged, this coxa magna, flattened, that is coxa plana. So this one you have to remember. Decrease in femoral angle, that is coxa vara less than 120 degree, sagging rope sign. Tangential projection of the edge of the deformed femoral head. It causes a concave curvilineal radiopaque line visible superimposed over the metaphysis. This is sagging rope sign. Due to projection of the edge of the deformed femoral head. Later, superimposed degenerative changes will be there, loss of joint space, sclerosis and osteophytes will be there. One of the DD adults with deformed femoral head is congenital hip dysplasia. This congenital hip dysplasia is associated with some degree of accompanying acetabular dysplasia. So this is about leg claw Perthes disease. Then coming to Ewing sarcoma of femur. So first we'll be telling pathology, then going to radiological features. It's a primitive primary malignant tumor of bone. Primary. Tumor cells derived from the connective tissue framework of bone marrow, originated from the marrow stem cells, which is derived from the primary reticulum. So they are called as round cell tumors. This is said by Oberlink. So predilection for marrow-rich diaphysis. Coming to age, now remember primary malignant bone tumors. One of the viva question, most common is myeloma. Second is osteosarcoma. Third is chondrosarcoma. Ewing is fourth. They may ask you. Age group 10 to 25 years age range, peak at 15 years. Younger age people, the lesions are they affect the peripheral skeleton. Older patients like 20 to 35 years, they present in the axial skeleton. Again, this male to female ratio 2:1. Clinical features, they present with pain with swelling at the site of the lesion. Soft tissue mass is palpable in more than 1/3 of the cases. One of the bone tumor which mimics like an infection is Ewing sarcoma. They have systemic symptoms: fever, anemia, leukocytosis, increased ESR, simulating an infection. Local elevation of the temperature with dilated veins and associated tenderness. Ewing sarcoma tumor, as it outgrows its blood supply, resulting in extensive degeneration and necrosis, causes inflammatory like symptoms. To location, obviously long tubular bones, in that femur most common, then tibia, fibula, humerus. Flat bones, this long tubular bones 40%, flat bones 40%. Long tubular bones 50%, flat bones 40%. Diaphysis, classic location. Flat bones, pelvis, innominate bone most common. Most common malignant lesion of childhood to affect the ischemia and pubis. 10% of all malignant rib lesions are Ewing sarcoma. 5% cases scapula is involved. 3.5 to 7% spine is involved, in that sacrum and lumbar spine. Feet, mandible, horizontal lambus, they are also involved. FNAC in conjunction with immunocytochemistry are effective non-traumatic method for rapid and accurate diagnosis. Coming to radiological features, classic presentation, it appears in a diaphysis, usually lower extremity femur is most commonly involved. It's permeate in its appearance, wide zone of transition. It's like permeate lytic destructive lesion with a wide zone of transition. Delicate laminated onion skin periosteal response will be present. Cortical saucerization is an early and characteristic sign. Purely lytic lesions are uncommon, with a mixed lytic and sclerotic pattern predominant in the tubular bones. Flat bone lesions, there is 1/3 of cases they demonstrate diffuse sclerosis. They represent normal bone formed as a reaction to tumor cells. Pathological factors, 5% of cases. Onion skin type of periosteal reaction will be there. Cortical saucerization, permeated destruction within the medullary portion of the mid diaphysis of femur. Disruption of the cortex, creating a saucerization appearance. Periosteal bone formation. 3 types of periosteal reaction occurs in Ewing sarcoma. Most common is obviously onion skin type. There is a delicate parallel laminated onion skin or onion peel type. It is caused by splitting and thickening of the cortex by the tumor cells. One more is a Codman's triangle. This layering is continuous with reactive ossification in the form of Codman's triangle occurring frequently. DDs for Codman's triangle type periosteal reaction: osteomyelitis, traumatic periostitis, osteosarcoma, malignant lymphoma. Third type is Sunray type of periosteal reaction. May also occur. DDs are metastatic neuroblastoma, renal carcinoma, Mets, and osteosarcoma. So most common is onion skin periosteal reaction. So normally this Sunray type of periosteal reaction, this radiating, they have a radiating spicules. They are referred as groomed and trimmed viscous effect. This perpendicular bony spicules are thinner and more hair-like than those of osteosarcoma. Ewing sarcoma is the most common primary malignant bone tumor to metastasize to bone. Osteosarcoma also metastasis to bone. Ewing sarcoma is the most common. Coming to metastasis, we have skeletal metastasis occur frequently and early, leading to extensive bone destruction. Spine common site for metastasis. Multiple lesions in one bone occur, described as skip lesions. Secondary spread to lung also occurs, with lung parenchyma and pleura being the favored locations. And this is about Ewing sarcoma. Remember, onion skin type of periosteal reaction, cortical saucerization, permeative bone destruction. Thank you.